Okay, great. We're going to go ahead and get started. I expect a couple more codes to be trickling in, but I am going to keep things very brief. But I do want to start by briefly sort of welcoming you to the session and introducing our speakers. Welcome to today's Health Equity Lightning Talk session. My name is Jess Maxett, and I am one of two technical directors in the Data Analytics and Research Group in the Office of Minority Health at CMS. During this session, you can expect 5 brief but highly informative presentations from 6 excellent speakers discussing critical health equity work around digital tools, resource libraries, and healthcare service coding to address key areas including maternal health, sickle cell disease, and food and nutrition interventions. The importance of lived experience insights and reducing administrative burden for truly optimized care will also be discussed. Lightning talks, just as an FYI, do not include time for Q&A, but I do encourage folks to jot down notes and thoughts that they might have during speakers' sessions and engage with them at the end of the session. Our first lightning talk will focus on coding for food. Coding for Food is a community-informed initiative aimed at creating new healthcare common procedural coding system, or HCPCS codes, to define a spectrum of food as medicine interventions as healthcare services. We have with us 2 presenters on this topic today, Kristen Suppies from Food as Medicine and Katie Ettman from Bolwell. Kristen and Katie.
Good afternoon, everybody. Can everyone hear me?
Yes.
Incredible. As I said, my name is Katie Ettman. It's lovely to be with you all here today. And I'm actually going to start with a story before we get to the jargon and HCPCS and what does that mean. And that is that in my role and capacity, I work on making healthy food more accessible in California from the San Francisco Bay Area. And some of what that looked like is the integration of food into healthcare and getting those services paid for. And we are incredibly fortunate that in California, we have used a federal Medicaid waiver, the Legend 15, 1915B waiver, if you're into the jargon side of things, to actually make it possible for our health plans, managed care plans, to cover a spectrum of food as medicine interventions. And so that can look like things like a produce prescription, where maybe someone gets a voucher or card and goes out into a grocery store and buys their own free fruits and vegetables so that they can help prevent, reverse, or treat a chronic condition. Could be a medically tailored meal that's delivered to their home. But as we talk about these and as we went to cover these in California, we realized that we don't actually have the infrastructure and systems to set these up to truly integrate into healthcare over the long haul. And so we went, yes, you can pay for these things. Community-based organizations can provide these services. Health plans can then get payment through their providers, their sort of traditional clinics, hospitals. But we were dealing with things like invoicing for those services. So a managed care plan would contract with a small community-based organization, and they would say, oh, yes, your patient has diabetes. Maybe it makes sense to provide them food in a healthcare context. Oh, wait, now that community-based organization needs to start dealing with things like privacy. They also have to deal with things like healthcare billing and claims. For lots of you in this room, that's probably like, yeah, duh, I got that. I can do this. But for some of our community-based organizations, that was not the case. And so instead, what we really realized was a problem is that we needed to not create a parallel system where CBOs worked with healthcare in one way and healthcare providers and clinics worked with healthcare in another way, but instead we had to truly integrate the infrastructure. And so we realized that we needed billing codes, medical codes to define the spectrum of services. And so we realized this was not just a problem in California. We're very lucky that Massachusetts, North Carolina, New York, they have all used these federal flexibilities to provide food-based services. And yet we were all coming up with our own distinct solutions for how to bill for these services. And so that is how Coding for Food, our initiative, was born. So that's a little bit of the story and how we got to this moment. We realized it was a problem in lots of states. And then we pulled together an incredible advisory committee to say, how do we solve this problem? How do we work nationally to fix the fact that we don't have billing codes, that we don't integrate fully into the system? So the thing I have written down is all of our incredible partners, because I can't miss a single one of them. So one of them is the Gravity Project. So they are a national consensus building group who helps come up with these medical codes. So the absolute experts. We're also working with the Academy of Nutrition and Dietetics, the Center for Health, Law, and Policy Innovation of Harvard Law School. For those of you in the food world, my name is Chilpy. Ceres Community Project, Chorus Community Health Plans, Elevance Health, Feeding America, the Food is Medicine Coalition, Food and Friends, the National Produce Prescription Collaborative, Project Red, the Teaching Kitchen Collaborative, the Western New York Integrated Care Collaborative, and then an individual physician who's a pediatric hospitalist, Dr. Emma Steinberg. And so this group that represents national organizations, small community-based organizations, physicians, health plans, is guiding this work to help us come up with new codes to define this full spectrum of food as medicine interventions. And the last bit, and maybe the most jargony bit here, is that word HCPCS. So the reminder here is that we provide these services, but we need to get them paid for so that everyone in the whole system is making sure we're not just providing free services. These are healthcare. They need to be paid for with healthcare dollars. And so HCPCS are our ability that code moves in a medical claim. So it goes up and down with the person, and it is trackable, and you can attach a payment to it. So that's why we are focused on that particular code set, and that is managed by CMS. So we are very lucky that we will be working towards those codes. And I'll pass it over to my colleague, Krista, to talk more about the specific project.
And HCPCS codes, when we talk about needing codes to support food-based interventions, people think ICD-10 codes, they think Z codes, we have LOINC codes. Katie and I have learned the wild west, Western world of coding over here. And HCPCS codes are very different than those. We have LOINCs that are for, screeners. We have the diagnoses codes, but the HCPCS are for the actual services or like the products that somebody is giving. So when Katie talked about medically tailored meals or produce prescriptions, those are the products, and we don't have codes to define those. In California, since they passed policy similar to a bunch of other states, in fact, 8 states now passed 1115 waivers that provide reimbursement for food-based interventions. California has a couple codes that are very broad umbrellas. And then they use modifiers that are still just as broad of an umbrella to identify a number of food-based interventions. So when you're going to evaluate these things, you can't quite tell who's getting a produce prescription, who's getting a healthy food box or a grocery delivery. And so when we talk about efficacy of these interventions, we really have no idea what's working because we're not able to actually code them properly, let alone being able to adequately bill them too. So this is a big problem. Back in December 2022, we brought a bunch of folks from across the nation together to talk about this problem. We had a webinar. It was called Back to Basics. You can Google it. Coding for Food-Based Interventions, I believe. It's a fantastic intro to the world of coding. And we also had a separate day where we talked about people's experiences on the ground in these states that allowed for reimbursement, but didn't have that coding infrastructure. Then cut to, from those webinars, we realized this is a really, really big problem. We actually have to formally create a project. Katie mentioned the advisory committee, full of these wonderful partners across the United States that we formed. And then over the fall so we had the webinar in December 2022. Then we had a whole another year almost go by, of, kind of gathering these folks together, thinking through the project, formally partnering with the Gravity Project. This past spring, we decided to launch our first request for applications. We decided to break this project down into 2 different phases. Phase 1, because there's a lot of food-based interventions. In California alone, I think you all have about 7? Yes, sorry. 7 some days, 9 others. There's a long list of food-based interventions. And as we know, if you look at the policy, there is different language depending on the policy, depending on the state for all of these interventions. So we have a lot of work to do essentially to figure out which interventions we need to create definitions for and which interventions need codes. So we're breaking this project down into 2 different phases. Phase 1, the interventions that are the most popular, that are the closest to reaching a national consensus on a definition. Medically tailored meals, medically tailored groceries, and produce prescriptions. Phase 2 is going to be kind of an iterative process from phase 1, but phase 2 are additional food-based interventions that we know also need code. Pantry stocking, behavioral education, cooking. We have a lot of states that allow reimbursement for kitchen equipment and cooking equipment like refrigerators and stoves, ovens. So all of that's going to be phase 2. Phase 1, we were just released a request for applications. We got a ton of applicants, which we're really excited about. And we actually just notified our final applicants. So we're waiting on confirmation right now. But if everybody confirms, across the 3 work groups, medically tailored meals, medically tailored groceries, produce prescriptions, we have 34 organizations representing 27 states total and 2 representing national services in scope. We're going to be kicking off these work groups at the end of August, and they will be meeting to reach consensus on the definitions for these food-based interventions all the way through December. In January, the Gravity Project will be taking those definitions and will be applying for new HCPCS codes. HCPCS codes are owned and organized by CMS. So they're the ones that then take that application and decide if they're going to approve it or not. It's kind of a black box. TBD what happens there. Then we're also going to be launching phase 2. All of those other interventions that we did not cover in phase 1. Again, that is an evolving process. Throughout this, we also are going to be hosting public calls. The Gravity Project hosts these monthly. And so that is kind of an open call to everybody in the room to get involved in those. If you want to weigh in on the consensus of the definition, those definitions, that is your spot. I will note that if you Google coding for food, you will find our website somewhere in the Google search. We tested it out this morning. And our mailing list is there. We highly encourage everybody to sign up for that. That is where we're going to be releasing the applications for phase 2. We'll be announcing what interventions are part of phase 2. And we'll also be announcing any of the public call opportunities that you all enjoy as well.
I think just the final thing before we close here is, so please, if you're interested, join those Gravity calls, come be a part of this process. And there are really multiple deliverables here. We are learning how to get new sort of social determinants of health codes through food, but there are probably so many other services in your state that also need these medical billing codes. And so thinking about how can we take this information and move it forward, how can you participate? And then once we hopefully secure those codes, getting them out and used in the public. How do we actually start making sure that our CBOs are using them, our community-based organizations that are healthcare providers know they exist? So it's going to take all of the amazing advocates in this room to say, hey, I knew about this project. They secured these codes. Now let's actually use them so that we have better data and a better ability to integrate these into our healthcare system so that we can really affect people at the baseline level of their needs, like you heard about this morning.
Okay. Our next lightning talk will focus on sickle cell disease, which is a lifelong and iterative blood disorder that affects over 100,000 individuals in the United States, the majority of whom are Black or African American or Hispanic or Latino. Today, Molly Lawson, who's a program manager at the Dalio Center for Health Justice at the New York Presbyterian Hospital, will be presenting on this topic, focusing on an effort by the Dalio Center to create a robust resource library of educational materials around sickle cell disease with an eye towards patient, provider, and community audiences.
Hi, thank you so much. As just mentioned, my name is Molly Lawson. I am the sickle cell program manager at the Dalio Center for Health Justice at New York Presbyterian in New York City. As a little bit of background, the Dalio Center was formed in 2020 and with an aim of identifying and addressing the root causes of health disparities. And one of our major undertakings was sickle cell disease. New York Presbyterian is one of the nation's largest integrated academic medical institutions. And across our campuses, we provide primary hematologic care for over 1,200 sickle cell patients. And over 60% of those patients are covered by public insurance. So together with our academic partners at Columbia University and Weill Cornell Medicine, we decided to focus on building a program to improve patient outcomes and experience, provide a more seamless transition from pediatric to adult care, and also improve on education and resources for patients, providers, and our community. So today, that's what I'm going to focus on and kind of these buckets of educational content and resources that we've built within our program. Prior to our program starting, clinicians really used resources from outside institutions, things that they created on their own. And it led to unstructured and overwhelming amounts of information. So we started with the very basic. We made a website. It's external facing website that anybody can access. Where we can put all of our content that we were going. We were also able to link relevant, important new data and literature. I'm so happy that somebody this morning talked about gene therapy for sickle cell disease. Then we created a pamphlet. Simple, very easy pamphlet. We put it in all of our sickle cell clinics with QR codes to that website as well as the URL on that. That's just an overview of what sickle cell disease is. Then we made 2 animated videos on what is sickle cell disease and how to treat sickle cell disease. Those are available in English and Spanish on our website, but also on our institution's YouTube video page. Once those were created, our pediatric hematology team came to us and expressed difficulties they were having educating their younger patient population, the 6 to 9-year-olds. Most of the content that had been created, including this lovely pamphlet, had been geared towards adult patients or parents of children with sickle cell disease. So we created a small interdisciplinary group to come up with the idea to make a workbook or coloring book, some interactive tool to be able to help kids learn about what's happening in their bodies. We made a story about a little girl who has a younger brother who keeps asking her questions about sickle cell disease. So she takes him to the doctor because she knows the doctor will be able to teach her everything. So we then took that to our sickle cell disease patient family advisory committee, and they loved the idea. They contributed to the story. They named the character. Hannah goes to the doctor. Hannah is the daughter of one of our parents on the PFAC committee. Hannah thinks she's famous. She is. She loves it. She has a book named after her. So our providers also love having this as a tool because it gives them a framework of guided conversations from one visit to the next. It also allows them to assess a child's reading ability and gives parents, this is a very unexpected outcome, gives parents the opportunity to have a safe space to talk about their sickle cell trait. They gave this to their child and they're feeling guilty, and now they have a safe space to talk about it because we address it in the book. That's kind of the bulk of our tangible educational content. Then we worked with an industry leader in implicit bias training. They came in and interviewed a lot of our patients and providers to get a really good understanding of what it's like to be a patient going through the healthcare system with sickle cell disease. You can imagine there's a lot of bias and there's a lot of racism that they endure through their lives in the healthcare system, and what providers have to the obstacles that providers have to jump over to provide good care to these patients. And that content just went live last week. It's on our internal LMS system for all of our providers to be able to take. But we also worked with the company to make it available at no cost on the vendor's website for individual use. So if anybody's interested, let me know. I'll tell you where to get it. And then, of course, central to all of this is patient and family feedback. So we host several patient appreciation days every year at several of our campuses. We bring providers, patients, their families, and community-based organizations together so that they can network, chat, provide resources to one another. And then the last thing that we do every year is we host an annual symposium to be able to provide new education to our providers. And the bulk of the people who attend are actually residents who are getting their educational training. And one of the things that we do is we bring in a panel of patients who have sickle cell disease or have been cured of sickle cell disease to be able to give that information. You can't learn from a textbook. And that panel has always been moderated by hematologists, where patients can express what it's like to live with sickle cell disease, what it's like to raise a child with sickle cell disease, or any other pertinent information that they think is necessary for a provider to know before they care for them. So that's kind of a bulk of what we've done. As we look forward, we are really excited to continue to engage our Patient Family Advisory Committee, who've been very engaged in this educational content, especially Hannah and her dad. And also we're working on a large-scale national awareness campaign. Thank you.
Thank you, Molly. I'm happy to introduce our next speaker, Dr. Garuja Lyons, who is Vice President of Diversity, Equity, Inclusion, Justice, Access, and Belonging at the American Occupational Therapy Association. Today, Dr. Lyons will be discussing links between historical trauma and health disparities and how lived experiences, including intergenerational lived experiences, can greatly inform and improve healthcare service delivery for Indigenous, Native American, and Alaska Native individuals served by CNAS. Dr. Lyons?
Good afternoon, everyone. I have to first acknowledge that I'm a Black and Indigenous woman of color, and I honor my ancestors, especially the land that we're on today. I have notes because I talk a lot. In 7 minutes, it's a challenge. So I have to look at my notes. So I am working as a chair at the American Occupational Therapy Association. And I work in a department with the longest name, DEIJAB. With that. And we've been doing our work for almost a year officially. We've been doing it for a while, but a year officially. And in the midst of that, I can really share that it's been somewhat of a challenge, as you all might attest, for the political scene, socially. These discussions that we're having today aren't always well accepted. And I had a chance to do some travels. I live here in Maryland, as we like to say, but I was able to travel to Alaska as well as Hawaii. I was on an iceberg and then literally on the island the next day. But being able to speak to the Indigenous populations really allowed me to think differently. And that, culturally intelligent programs and care can really improve health outcomes. And we need to expand these. And I want to share some of our resources we have. If you go to AOTA.org, our DEIJAB resources can be found there within our toolkit. But I realize we have our work to do. We have a lot of work to do. We have the forgotten people, if you will, which are part of my ancestry. And I wanted to start off with a definition from the CDC, which identifies that health disparities are preventable differences, and the burden, disease, injury, violence, or an opportunities to achieve optimal health experience by socially disadvantaged groups and populations. Preventable healthcare disparities persist for our tribal communities, such as Indigenous people, Native Americans, and Alaskan Natives. And despite funding, stopgap funding, we've seen that there's been dramatically underfunded resources for these populations as compared to CMC funding per capita. Not only do we have such disparities remaining for decades, yet they are increasing. So for these populations, the unique impact of mass traumatic events has pervasive negative health outcomes throughout generations. Adverse childhood lived experiences remain, and the compounding collective experiences results in the penetration of both vicarious and genetic trauma. While increased attention on social determinants of health, and I'll redefine that for you in a bit, exist, cultural and intergenerational factors are often absent from the discussion of health disparities, health inequities, and focuses primarily on the present moment. Yet, these injustices cannot be viewed as finite. It is not a person's race or ethnicity that determines their outcomes. It is the social factors of their context and environment driving the quality of care they receive. It is the trauma that impacts if one seeks proper care, and this improper care is actually reported. Indigenous populations continue to have the highest rates of poor health outcomes and the lowest life expectancies within the United States. To this end, the Indigenous Healthcare Service assessment of health inequities must include methods to employ actionable steps to address historical trauma. Currently, There are efforts to narrow the disparity gap by connecting healthcare services to social determinants of health. Programs such as IHS have emerging methods to assess and establish intervention, expanding the medical model. These initiatives emphasize the intersection of health outcomes from a biopsychosocial factor. Yet with such chronic disease, early life expectancy, and mental health diagnoses, this epidemic requires us to reassess how we look at these systemic factors. Training and service provision must not only be trauma-informed, but trauma-responsive. There must be an acknowledgement of the historical trauma and analysis of recent data and research. While Native and Indigenous populations may have healthcare costs provided for free or low cost, there still are long-term effects that might be connected to their DNA. While determining causation is challenging, we can't ignore this fact that there is an epigenetic connection. And it's not just poor diet, right, that may be infecting someone's health, but hence their potential this highlights the gaps of service provision. I want to encourage you to think about social drivers of health, rather social determinants of health, that what's in one's environment, the context, that historical connection is actually driving one's health outcomes. In my role as vice president at AOTA, we recognize a few things you will all consider to do and to support. The expansion of telehealth programming for rural and tribal communities. Consider proper data collection when we're looking at social drivers of health literacy, one's preferred language, including indigenous languages, gender identification, and sexual orientation. And we need to pay more in terms of reimbursement for healthcare workers that are family members to allow people to stay within their communities and to rest and age gracefully at home. And we need more healthcare professionals that look holistically. As in the field of occupational therapy, and I know I am biased, however, being able to look at one's, not only their safety needs, but their sensorial needs, and still continue to have a cultural context that really supports that individual. Lastly, mental health services must include our qualified healthcare workers, and we need to expand that definition, which currently doesn't always include one like myself, who has studied mental health for the majority of my career, but our services aren't always reimbursable. So we need to expand that role for more trauma responsive care. These are doable and reachable goals that I encourage you all to consider, and CMS and IHS to consider as well. I'm always reachable. My name is Dr. Varlisha Lyons, and my email is vlyons@aota.org. Thank you.
Thank you, Dr. Lyons. Our fourth lightning talk will focus on maternal health, specifically on the potential for digital health tools to reduce disparities in maternal health outcomes, as well as barriers to successful implementation of these tools. I'm happy to introduce Priya Bathicha, who is founder and CEO of New Health, and will be presenting on this topic today with a special focus on digital equity and literacy in the maternal health space.
And I also have a script because it's hard for me to send it. If you are in this room, you already know many things about maternal health in our country. You know that the U.S. has the highest maternal mortality rate of all developed countries. You know that Black, American Indian, and Alaska Native women are 3 to 4 times more likely to die of pregnancy-related complications than white women. You know that the CDC estimates that over 80% of maternal deaths are preventable. And you know that even one maternal death is too many. That's why so many are committed to finding solutions. That includes in-person and digital solutions that can be used together to improve maternal health. Today, I'm going to focus on digital tools, mobile health apps, patient portals, telemedicine, and more. These tools are being used to improve access, care, outcomes, and patient experiences. Let me give you some examples. Luna Joy provides virtual access to mental health therapy, counseling, and medication management to moms who otherwise would have gone without help. Maven offers access to virtual doulas who provide support to mothers. These doulas are positively affecting C-section rates and improving birth experiences, despite being virtual. BabyScripts educates, engages, and empowers women with technology. The remote patient monitoring tool alone has led to early diagnosis and treatment of preeclampsia. Northwell Health uses an AI-driven chatbot to educate and identify urgent concerns during and after pregnancy. This ensures that women get help quickly. We continue to see an increase in the use of digital tools like these. Deloitte recently surveyed 2,000 people who had been pregnant in the past 2 years to see how they use these tools. Nearly 50% of them used them to access care. 36% used them to communicate with their care teams, and 77% used them to monitor reproductive cycles, manage weight and nutrition, support mental health, and to educate themselves on maternal health. Despite this, we have a gap. We have many individuals who aren't able to benefit from digital tools. They may not have access to Wi-Fi or the devices needed. They may not be able to access them because the tools aren't aimed at those on Medicaid or those without means. Individuals also face obstacles navigating, understanding, and communicating information in a digital format. As we move forward, we must focus on digital equity and give all women a fair and just opportunity to access and understand these tools. Let me give you 5 steps you can take to promote digital equity. The first, commit to designing and implementing digital tools in a way that all patients can access and understand. CommonSpirit has embedded equity into their strategy. They ask questions about digital equity throughout the design, implementation, and evaluation phases of these tools. And recently, ARC released a digital healthcare equity framework to help organizations do this. So check it out. Number 2, create a process to engage diverse patient voices. This can be done by creating avenues for underrepresented patients, communities, and providers to give feedback. For example, hospitals could engage moms with low health literacy to understand their communication preferences and tailor services to meet their needs. Number 3, track patient engagement to understand which patients are using digital tools and which are not. Let's go back to CommonSpirit. They implemented a program to provide culturally competent navigators or docents to pregnant moms. They implemented, from their analysis of data, they learned that Spanish-speaking individuals were not using the tools, despite having access to Spanish-speaking docents. They found that for some communities in California, providing a Spanish-speaking docent wasn't enough. They actually needed docents that spoke the same dialect of Spanish as these communities. Number 4, select solutions that minimize barriers to access. Boston Medical Center did this when they selected a remote patient monitoring solution for postpartum hypertension. Their patients had smartphones, but they didn't have consistent access to Wi-Fi or a data plan that could be used to support a video framework. As a result, the team selected a tool that uses the local cellular network, making it accessible to more individuals. Number 5, design culturally competent digital tools. This includes offering tools in different languages or using more videos, images, and emojis for those with low literacy levels. It also includes ensuring tools are culturally sensitive and inclusive. InnovCares, for example, connects pregnant women with culturally aligned providers, both virtually and in person. Every clinician that works with InnovCares completes an intensive, culturally informed training, including a focus on health equity, implicit bias, and active listening. So I'll end with a reminder. Digital tools are not the silver bullet answer to our maternal health crisis. After all, you can't deliver a baby. It's 3. At least not yet. Okay? But we have to ensure individuals can access and understand digital tools. And when we combine those digital tools with in-person solutions, We have a powerful path forward to improving maternal health. When we do that, we can reach into the lives of our patients. We can ask them about their goals, which I promise you include more than surviving childbirth. We can listen. We can show up for women the way they need us to show up. And we can prove to them that they can trust us. I hope you will take these strategies back to your organization and that you will continue to improve how you deliver care to women in pregnancy and beyond. Thank you.
Thank you, Priya. Our fifth and final lightning talk from Stace Mendel, who's Acting Director and Deputy Director of the Office of Burden Reduction and Health Informatics, also known as OBRI, at CMS. Broadly, OBRI focuses on identifying and creating efficiencies across the healthcare enterprise by integrating technology, policy, regulation, and stakeholder engagement to improve healthcare quality and health outcomes. And today you'll hear from Stace on ways to optimize healthcare delivery as a means to improve the lives of individuals who are served by CMS's programs. Stace?
So first of all, I just want to say thank you, and what amazing presentations. Thank you all for that. I feel, wow. And I have notes because, in my memory probably. I get a little nervous before I present. So Stace Mendel, I guess I'll start by letting you know that I'm a nurse and a social worker by background. I know firsthand the experience of avoidable administrative burdens, but I also want to just acknowledge that their burden comes in many forms. There are administrative burdens. There are the burdens that really that our patients, individuals, that family members, their loved ones endure in healthcare and outside of healthcare. So burden is expansive. I'll probably talk mostly about what we're doing from more of the avoiding administrative burdens perspective. But I do just want to acknowledge that burden is broad, and that burden that affects the healthcare workforce affects patient care. And that is something that I think we really learned a lot through our experiences through COVID. So just some quiet thought for folks who are in the front lines and managing through that. So yes, I have definitely experienced administrative burdens firsthand. I was there a long time ago, back in the day when we transitioned from paper charting to the electronic healthcare record, actually in San Francisco, having multiple places to do data entry, and still a paper chart, and still try to take care of, I think at a time like just saying. So the Office of Burden Reduction and Health Informatics that I am extremely honored to be the acting director for really does emphasize its and sort of centers its work on looking at avoidable administrative burdens, and we don't do. We're really not black box. we really sort of pride ourselves in using human-centered design, customer engagements, and surveys, and requests for information, and really talking to people, listening sessions to really understand the problem spaces that are going on. In fact, we had a team that just returned from the U.S. Virgin Islands and Puerto Rico to really understand the engagement challenges, the challenges for our clinician workforce there. So really gathering that information. And I actually went on some road trips to rural parts of the United States and saw and heard and learned firsthand about not just the challenges, but the incredible work that individuals go through to really overcome those challenges. Everything from broadband, and let me see if I can find its, a cell phone service, to really needing landlines to provide mental health services. It's just the whole gamut. Really impressive, the work of the community health workers in addressing maternal mortality for Black women. I mean, it was phenomenal the things that people do to overcome those challenges, which are also known as burdens, which affect individuals across the United States. Super proud, super pleased that the office hosted CMS's inaugural conference on burden reduction. That was last November. I don't know if folks were able to dial into that, but it was titled Optimizing Healthcare Delivery to Improve Patient Lives. And it had over 2,500 registrants, 1,000 folks all day long on the line. Lots of information and reflection coming through the chat on that. But the conference was sort of centered on not just understanding the challenges with these phenomenal panelists, but also the solutions, the creativity that was coming across through the different healthcare systems, through regulation, through regulators, through the vendor community. And one of the main takeaways from that conference was, something that we knew, but it really underscored it. It's going to take a community. CMS has, the leverage that it has, but we're just one regulator. There's the states that are regulators. There's the Joint Commission. There's academia. There's the vendor community. There's the hospital systems or healthcare systems at large. There's also culture, and things that we have ingrained in. Why do we do this? So it's going to take a community, and that really resonated out from the conference. And so we're having some roundtables to really dig into some of the details and serving, in essence, in a way of bringing people together to solve burden together. In her opening remarks at the conference, our wonderful administrator, Chiquita Brooks-LaShore, said that now is the time to address the challenge of administrative burden in our healthcare system. We have to. Our patients need that, and our healthcare workforce needs that. So to that end, I want to talk a little bit about a new initiative that we're developing for 2024, and it's called Optimizing Care Delivery, the CMS framework to reducing avoidable administrative burden. Its vision is centered on how we can work together to reduce avoidable administrative burdens. And we really want to bring together, as I was talking about, to mitigate avoidable administrative burdens and align in our understanding the causes, the contributors, and the impacts of that avoidable burden. First, by understanding the effects that it has on our patients and our workforce. I was honored to be able to moderate a many-plenary panel at CMS's Quality Conference. The panelists talked about the effects of avoidable burden on the healthcare workforce and what that translates into safety, what it translates into bias, what it translates into the loss of empathy. It has real downstream impacts. And that's why, I'm so glad to be able to be here to talk about this today, because it really is going to take all of us together to address it. But in the framework, we're thinking of administrative burden in terms of unnecessary, duplicative, redundant, or outdated requirements and process that affect and impact the healthcare delivery. And within the framework, we're listening to what we're hearing. And there are basically 7 priorities that we have drafted. I would love to hear your thoughts on what you think about those priorities. Number 1, to reduce avoidable burden and care delays associated with care approval processes in CMS programs, sometimes known as prior authorization. To improve safety and reduce administrative burden in care transitions. To reduce avoidable burden associated with duplicative or outdated data reporting requirements. To leverage technology to accelerate innovation and the adoption of the best practices to reduce burden. To integrate the patient and caregiver voice on opportunities to address challenges that contribute to inequities in care. To address well-being and the experience for healthcare workers across the healthcare ecosystem and enterprise. And to convene and support public-private partnerships to advance burden reduction efforts. To support these priorities, CMS has already advanced on several policies and initiatives which I think will lead to real improvements. One, that you may know about, I'll just talk about a little bit, was the final rule that we finalized called Advancing Interoperability and Improving Prior Authorization Processes, which was based on extensive stakeholder input and public feedback. 36 listening sessions, lots of RFI feedback, lots of, all you have to do is like basically listen to the news, to know that the processes associated with prior authorization are challenging. We hear loud and clear. I heard a lot about it on the road trips, about prior authorization processes and how much it takes. So to take those processes and make them interoperable so that we need to do, we need medical service X, and on the computer, the information for what's needed for authorization is provided. Patient knows what's needed. The provider knows what's needed. A decision is made within a reasonable period of time. All of that serves to improve patient care delivery. We have heard loud and clear what happens when there are denials, the time it takes to, and the effort that it takes to go through the process. Oh, my time is wow, that was fast. But anyway, so that regulation, really at the end of the day, it's technology, but at the end of the day, it's really improving patient care delivery. So to that end, the critical input that we received from the field provided us with the human impact of how avoidable administrative burdens specific to the processes involved with prior authorization have impacted patient care and contributed directly to clinician burnout. The policies laid out in regulations are really aimed at improving those processes for reducing the burden and the impact on the patients and on the family members and on the clinicians. Through our Universal Foundation initiative, we've been aiming at streamlining quality measures across CMS programs. And then to advance health equity and access to care, we've established policies to implement Medicare-funded physician residency slots with priorities going to hospitals and training programs and geographical areas demonstrating the greatest need for additional providers. I heard a lot about that while on the road trips too. When we're successful at removing unnecessary steps, we give back time to clinicians to focus on what truly matters, the health and well-being of the people they care and themselves. But none of these priorities can be truly addressed without the support of you, our public and our private sector partners. So we need your input. We want to hear from you what your priorities are and what you're encountering as challenges. Also, what your solutions have been. As we explore our framework's priorities, we want to understand what your organization is doing. CMS is committed to improving customer experience by identifying issues and root causes. We do that through our that impact health equity, healthcare delivery, access to services, inefficiencies, and burden experienced by providers and patients to ensure that the customer experience is in CMS's policy writing and operational work. As our Deputy Administrator, John Blum, said in November, CMS's commitment to addressing these issues is not just a policy initiative, but a transformative step in reshaping the healthcare landscape. So I invite you to, you can just go and search at OERHI, and we should pop up. But we have in there pits where you can send comments and thoughts and ask questions. You can also visit us by going to cms.gov and then clicking on priorities, key initiatives, and burden reduction. That's another way to get to us. So thank you. This is back.
I just want to remind you all, if you have questions, comments, want to engage with the speakers, they'll hang back up here. So please come and do that. And thank them again with me.